respected senior professionals and dear friends. So dear doctors, my talk will be on the premix insulin in the management of the type 2 diabetes, and I am showing the two cases. So case based discussion also will follow it. In the next few minutes, I would like to talk on the disease burden and the overview of the diabetes. What is the role of the postprandial glucose? Importance of the tailoring the insulin as per the patient's need, and two case studies, and finally few conclusion remarks. Since the disease is very high in Indian population, every 6 person with diabetes in the world is an Indian. So nearly more than the 10 crores. This is the 2022 December. Right now there are the 12 crores of the diabetics in Indian population, and unfortunately 80% of the Indian diabetic patients have the HbA1c more than the 7% in spite of taking 3 antihypertensive medications. So our people, our awareness is very poor, diagnosis is at a later stage, and initiation of the metformin is very easy and being done by every clinician. But unfortunately, uptitration of the metformin or a combination of the different drugs with the metformin is not being done. Even if the people are on the 2 or the 3 antihypertensive medications, but still, hypoglycemic agents, but still the HbA1c is beyond more than the 7% in 80% of the Indian population. So that clearly shows that our control of the diabetes is very poor, and a lot of our people are living with HbA1c more than the 9 average HbA1c in Indian population. So a lot to be done to reach the HbA1c in most of our people at 6 or 6.5 or the 7 or not more than the 7.5 in most of our individuals. These are the epidemiological studies, IDCI, DiabCare, Achieve, Present, Improve, and the ICR India study. And lot of the studies, these are the epidemiological studies. These are very important epidemiological studies done in Indian population. The range of the participants from the nearly the 1,000 to 3.5 lakh population. And if you see here, the HbA1c is average HbA1c is somewhere between 8.2 to 9.3, 9.2, 8.9, etc. And the fasting blood sugar say beyond 170 or 190, and postprandial blood sugar beyond 280, 250, 260, etc. So all these epidemiological studies clearly showing that our people with diabetes are living with HbA1c high, postprandial high, fasting blood sugar very high. What is the risk with uncontrolled postprandial hyperglycemia? See, postprandial hyperglycemia is an independent risk factor for the macrovascular disease. So for a given blood sugar, lot of our people are having the macrovascular disease. That means your myocardial infarction or cerebrovascular diseases or peripheral vascular diseases starts when the blood sugar is, postprandial blood sugar is more than 141. So 141 to 199 is pre-diabetic or impaired glucose tolerance or postprandial hyperglycemia. So at this juncture, a lot of the people are having the macrovascular disease, increased carotid intermediate thickness that leads to the cerebrovascular diseases, a decreased myocardial blood flow or volume that leads to your acute myocardial infarctions, impaired early diastolic dysfunction that leads to the heart failure, increased oxidative stress that leads to the lot of weakness, etc. Increased inflammatory markers, so that leads to the vascular ill health, increased risk of the retinopathy, so they may be the non-proliferative or proliferative diabetic retinopathy, and increased risk of the pancreatic cancer. So nowadays the cancers are also very high in the diabetic individuals, not only in the diabetes, even the non-diabetics. We are seeing there is a tsunomic proportion of the rise of the cancer cases or oncology cases in India in the last 1 or the 2 decades. And earlier we used to have only Tata Memorial or Adyar Cancer Hospital or CMC Vellore to send the patients to the oncology. But now even in Kakinada we have the 2 full-fledged cancer units. We have the 6 to 7 cancer units in Visakhapatnam, and we have the lot of the cancer centers, maybe more than the 25 in Hyderabad. That clearly shows the incidence of the increased incidence of the oncology, and most probably because of the uncontrolled diabetes, because of the uncontrolled hypertension, obesity, and faulty food habits, air pollution, sleeplessness, etc. See, the more patients achieve the HbA1c targets by adhering to the postprandial glycemia targets than the fasting. See, if you see these 2 slides, in one slide, the fasting blood sugar is responsible for the high HbA1c in about the 64% of the population. Whereas if you see the postprandial hyperglycemia, that is responsible for 94% of the population. See, most of our Indians, especially our Godavari people, they are in the postprandial or post-absorptive stage in about 18 to 20 hours a day. True fasting means mostly between 2 a.m. to maybe 6 a.m. or the 7 a.m. And remaining period, either we are in the postprandial or post-absorptive stage. So, to reach the HbA1c at our 6.5 or 7, we have to concentrate more on the postprandial hyperglycemia and also the fasting hyperglycemia. A large proportion of the patients with type 2 diabetes will require the insulin for maintaining the optimal glycemic regulation that is necessary to prevent the complications. Why are we are treating a diabetes asymptomatic disease? Because to avoid the complications, to prevent the complications. So to prevent the complications, we need to keep the HbA1c at the normal levels. It is even in spite of the 3 OHs, we are not reaching it. Then you have to use a good drug in your hand, which is a wonderful drug to control the blood sugars, is obviously the insulin. So the take home message is, whenever the blood sugars are very high, in spite of the many OHs, then there is always a role for the insulin therapy. So that is here we are lagging in India. See, insulin is the most underutilized drug in Indian population, even though it is one of the best drugs to treat in diabetes. A few stories about the insulin. So this story is exclusive for the Aman, a medical student from Srikakulam. See, this is the discoveries of the insulin. See, we give a lot of the respect to the Banting and the Best. Banting is not a physician or endocrinologist. He is an orthopedic surgeon like our Ramana Rao sir. And Best is a medical student like our Aman. You are Aman, no? Alright. So, Banting was posted in physiology department from the orthopedics department as a tutor in physiology. And he requested the professor of physiology, MacLeod, to give him one lab for the pancreatic experiments. But MacLeod initially he denied the request of the Banting to give any lab. So in spite of the many requests, so MacLeod was not happy to give a lab to the Banting. Then the Banting addressed to the Dean, Dr. Kameswara Garu, to pursue the matter, and he requested Raman Rao sir to give one lab. So not Raman Rao sir, maybe our Sri Ramal Naidu sir, to give one unused lab to Banting to do the research on the pancreas. So MacLeod, so because of the Dean's request, he has given one unused lab to Banting to further study the pancreatic experiments. Then the Banting requested one fellow to assist him, give him one fellow. But no medical student is interested to work with the Banting because Banting and the MacLeods are not the good friends. So if anyone is helping to the Banting, he is going to fail in the physiology examination because the professor is not interested in Banting's request. So on the coin test, Aman got the opportunity, our Best got the opportunity to work with the Banting. So finally the result you all know. I think if you see any drug in the world so far, one of the top best drugs, one is insulin. So the big credit goes to the orthopedic surgeon Banting and a medical student Best for their invention of the insulin way back in 1921, and they got the Nobel Prize next year, 1922. And in fact, so far 8 Nobel Prizes were given for the insulin. That is the only molecule which got the 8 Nobel Prizes so far is the insulin, for its introduction, for its discovery, and later for its A chain and the B chain, 21 amino acids, 30 amino acids. Then the human insulin, that is for the research, say biomedical engineering from the E. coli, and later the analogs, etc., etc. So far, so they got the highest number of the Nobel Prizes for the insulin and its different parameters. So the Kolip is the one, he is a physics head, and he made the impure insulin to the purified form. And here the Thomson is the first person who got the insulin molecule. See the December 15, 22 child with an anabolic state, in a catabolic state. Now after just 2 months of the insulin therapy, so chubby. In the same way before the insulin therapy, 7 years later, at that time, before the 1921, if anyone is diagnosed with diabetes, almost like a death sentence. They used to live for 6 months, less than the 6 months, because they get the diabetic ketoacidosis, they get the severe dehydration, they were infected with the sepsis, they were infected with the tuberculosis, etc., and they die. So no one lives beyond the 3 to 6 months after the diagnosis of the diabetes. But big thanks to the Banting and the best, now you know that 80 years, 90 years, 60 years is possible. Today I have seen one professor who got the diabetes at the age of say 40 years industry. More than the 40 years industry of the diabetes, more than 30 years industry of the diabetes. So common nowadays just because of the big thanks to the insulin and its a beautiful mechanism of the actions in controlling the blood sugars. So this is the timeline. So we started with the 1920. Now we are in the 2025. We got the so many advancements in the insulin therapy. So this is the human insulin. So earlier the porcine and the bovine insulins. So from the beef and the pigs, they got the pancreas, and then they developed the insulin. But later it's very difficult because the incidence of the diabetes is increasing because of the urbanization, because of the industrialization, and they have to kill all the beef and the pigs for the insulin production. So it's not possible. Then they made it as a biomedical engineering technology from the E. coli. Now they are getting the human insulins almost close to our human insulin, A chain and the B chain. So earlier beef and the pig insulins, they differ from the human insulin. That is the reason allergic reactions are very high and the control is not that good in beef and the pig insulins, whereas now the human insulins we are getting it. So we have the regular insulin. So that is the clear preparation. It can be used through the IV, IM or the subcutaneous. Usually we use the IV or the subcutaneous. When the fellow is absolutely normal, we use the subcutaneous. When the fellow is very sick, hospitalized, we use the intravenous. And it starts acting in about 30 to 60 minutes. So that is the reason we have to give your insulins, your regular insulins, at least 30 to 45 minutes before the food. That's how we have to give the regular insulins. Then we have the NPH insulins, that is the cloudy preparation. Administered only subcutaneous, not IV, because IV preparation means acute conditions of the acute complications, where you have to give only regular insulin. Whether the patient is in DKA or in acute myocardial infarction or a CVA or the sepsis, always use the regular insulin, not the NPH insulin. So premixed insulins, that is a very boon for the Indian population. So far, the highest sales in India as per the insulin preparation is called premixed insulins, your mixtars or hum insulin 30/70 or Humalong, etc., etc. So because of the ease, it has both the regular insulin and the NPH insulin. If you take the 30/70, that means 30 is the regular insulin and 70 is the intermediate acting insulin. Whereas the 50/50 is also there because we take a lot of the carbohydrate, especially the rural Indian population. So we give 50/50 there. 50 is the regular insulin and 50 is the intermediate or NPH insulin. So limitations of the conventional human insulins, they do not mimic the basal or the physiological insulin profile. However, in view of the relatively low cost, regular and NPH insulins will continue to be widely used in the Indian population. So this is the why you have to give the injection 30 to 40 minutes before it, because the insulin is in the hexameric form. It has to be converted to the monomeric form for its therapeutic action and takes about the 30 to 40 minutes. So most of our people, if you don't tell this thing, so they take the insulin and then they take the food. So what happens? Immediately after the food, your postpone blood sugars will shoot up. But this insulin will take into the action only after 30 minutes or the 40 minutes. So always the postpone blood sugar is very high, and then the insulin action is following it. So suppose if you give the insulin before 30 minutes or 40 minutes before the food, then by the time the blood sugars are high, immediately the insulin is there to control it. Then the people will have euglycemia. So this is a very basic and the most fundamental thing, that whenever the patient is taking the regular NPH insulins, so better to give it at least 30 to 40 minutes before it. Now we have the analog insulins. Then there is no time gap. You need not wait it. Just within the 5 minutes, you can give the analog insulins. See, ultra rapid acting analogs, that is the FIAs, within 2 to 3 minutes, so it starts acting. So even though if you miss the injection, immediately after food also you can take it, because immediately it starts acting, because they are in the monomeric form, no conversion, so no time delay. So very flexible insulins. Rapid acting insulins, you have the three, the Lispro, Aspart and the Glulicin. So that these also can give within 5 to 10 minutes before the food, or just immediately after the food also. Long acting analogs, they are very useful drugs. Glargine, your very favorable long acting insulin. Now we are having the Deglutec also. So the lantus or your glargine acts for about 18 to 20 hours, not truly 24-hour acting insulin, but you take the deglutide that acts beyond the 24 hours, maybe 36 hours also it acts. So these are the profiles, how they act it. So coming to the reduction of your HbA1c. See why you are using these drugs? Because to reduce your HbA1c. So average HbA1c is about the 9%. Suppose if you take the diet and the exercise, you can control the HbA1c by 2%. And if you take any drug, maybe 1.5 to 2%. But insulin, indefinite, unlimited. At any time, at any given HbA1c, suppose the HbA1c is that today I have seen one fellow with HbA1c 13.8. So he is referred from the ophthalmologist for the dimness of the vision. He approached the ophthalmologist, and the ophthalmologist says that both as proliferative diabetic retinopathy, the sugar, random blood sugar is 480. So go to Dr. Jawahar for the proper control of the diabetes and then come back to me. So for the proper management of your retinopathy. Then I examined, then I see the HbA1c, it is 13.8. Imagine. So now he is just aged about the 48 years. He got the diabetes at the age of 38 years. So last 10 years, he is a diabetic. Now the 13.8, and he had the peripheral diabetic neuropathy. He had the diabetic nephropathy also. He didn't know that he is living with bad kidneys. Now I checked after the retinopathy, I told him that retina and the kidneys are very close friends. Let us see your kidney function. The creatinine is 2.8 and urea is 68. So already had the 3 microvascular complications. So one is neuropathy, second one is nephropathy, another one is retinopathy. So you have to see the macrovascular complications in him. So he is a poor fellow. So this is a very, very important. So you can imagine his lifespan. You can imagine the quality of the life in him. So unfortunately, even we are living in Kakinada or in urban areas with a lot of the good subject in us, still a lot of our population, they are taking the diabetes as a very so simple. So all these years, he has met only 3 or 4 doctors. And last 10 years, his visits to the doctors are hardly 8 times or the 9 times. The same drug he has been using it. Same tablets he is using it. See, the follow-up is very important. And increment in the dosage is very important. And see the urea, creatinine, HbA1c, fundus examination, and then the renal parameters, lipid parameters, thyroid. So these are very, very important. Once in a while echo and once in a while TMT. So these are the very, very important. So always I tell my patients that treatment of the diabetes is not costly, but treatment of the complications is very costly. Now he has to spend at least 12,000 for each visit for that injection in the retinopathy. So for every visit, he has to spend about 12,000 to the 15,000. So maybe 20 sittings, 25 sittings, 30 sittings, we don't know that. But whatever the vision is lost, that is lost. So these treatments are only not to further destruction. So whatever the destruction of the retina is there, that is gone. So imagine now the nephropathy and then other things, etc. So my humble request to all of you is, whenever you find any diabetic, so please tell him that they need not change the doctor, but continue the same doctor, but they have to get the frequent investigations. So it's very, very important. At least once in 6 months or once in a year, they should know their HbA1c. They should know their blood pressure. Then I checked the blood pressure. His blood pressure is 210 by 140. Imagine. So accelerated hypertension because of the kidney failure, because of the CKD. So hypertension can be an effect or a cause for the CKD. Insulin in the Indian context. So are we starting the insulin at the right time? So intensive treatment with OADs over a certain period has shown the control, but eventually glucose levels continue to rise the state. That is the most important in the diabetes. See, the diabetes is an aggressive disease. It is a dynamic disease. It is a progressive disease. So what is right today may not right after 6 months or the 1 year. So ఈ రోజు మనం ఇచ్చిన ఇన్సులిన్ 20 units, that is sufficient. Euglycemia వస్తుంది. But after 3 months or the 6 months, again the blood sugars will go up. So there is always a role to upgrade or up titration of these dosages. In India, insulin therapy is initiated when the HbA1c levels have deteriorated to around 9%. 9% ఎక్కడ స్టార్ట్ చేస్తున్నాం మన ఇన్సులిన్? In India, we are using only OHS even at the 10, 11 also. So we are using the insulin at the HbA1c level more than the 11, 12, 13 only. So it is time to start the insulin much early before a complication starts. So Indian physicians prefer to use twice daily dosing of the premix insulins. So I told you that. See the black one, 59% the premix. So that is because of the ease మార్నింగ్ ఒక షాట్, నైట్ ఒక షాట్. సో మన పేషెంట్స్ ఎవరు వాళ్ళు తీసుకోలేరు సార్, ఇంట్లో ఎవరో ఒకరు ఇచ్చేస్తారు. సో బిఫోర్ బ్రేక్ఫాస్ట్ వన్ షాట్, బిఫోర్ డిన్నర్ వన్ షాట్. సో దట్ ఈస్ హౌ it is useful for most of our population. What are the indications for the insulin therapy? In newly diagnosed patients who are symptomatic or have one of the following. See, the newly diagnosed, even at the time of the diagnosis of the diabetes itself, some people they require the insulin therapy because suppose it turns to be a type 1 diabetes. So obviously insulin today, insulin tomorrow, insulin ever. Elevated glycemic parameters. When the A1C is beyond 9, fasting more than 250, PPG more than 300, we call it as a glucose toxicity. So the antidote to the glucose toxicity is the insulin. Positive ketosis. So ketone bodies are the positive. Again, we have to use the insulin. Catabolic state. That means there is symptomatic. Weight loss. So unintentional weight loss in spite of the good appetite. So definitely have to use the insulin. Hospitalized patients. Any condition. Hospitalized with a sepsis or AMI, etc. So they need the insulin. Pregnancy. So definitely they need the insulin. And planning to the pregnancy. So definitely should not use any drug except the metformin before the pregnancy. So when patient presents with the metabolic or the cardiovascular or medical or surgical or obstetric crisis, so obviously insulin is the safer one. So these are the important indications to use the insulin even at the time of the diagnosis of the diabetes itself. But the most important indication is this one. In patients with an already established type 2 diabetes, if a trial of adequate doses of the 2 or 3 non-insulin agents, that is OHS, for 3 to 6 months fail to achieve the A1C to target levels, if organ dysfunction contraindicates the use of the intensive oral agents, then the addition of the insulin may be justified. In a single word, OHA failure. That is very common in our practice. So whenever the patient is taking the OHS, if the sugars are still high, in spite of the 3 or the 4 or OHS, then there is a definitely role for the insulin therapy. I think this is the most important indication to start the insulin therapy. A 44-year-old male bank executive meets you with history of the newly detected. Is a newly detected and asymptomatic type 2 diabetes because the runs in families. Fasting is 326 and post breakfast is 463. He has been exercising regularly till 3 months ago but follows a sedentary lifestyle now. What would you advise to bring down his glucose levels? Insulin or oral medication? So obviously insulin because he is in glucose toxicity. So the fasting nearly 300, above 300 plus. Postprandial 400 plus. Asymptomatic. But still there is a role of the insulin because he is in glucose toxicity. What are the barriers to the insulin therapy? Once on insulin, I will get addicted to it. Insulin is the last tool to use. Insulin means frequent hypos. No doctor, give me 1 more month. I will show you. So these are all the common barriers the patients request to us. Once on insulin, always on insulin. Doctors, insulin has many side effects. If you do not show good control, next time I will put you on the insulin. So a punishment to the patient and the guilt. So these are all some of the barriers to use the insulin. And fear of hypoglycemia, needle phobia, inconvenience, etc. So initiation, start low and the go slow. Frequent titration of the doses. Patient education is a must. This is the very, very important. That's what Professor Jocelyn told. So the one who knows diabetes most lives longest. So the patient education, medical education is very important as far as the diabetes and insulin is concerned. So which insulin I will start? So is it basal insulin? Is it a premixed insulin? Is it a basal plus or basal bolus? So usually we start with the basal or the premixed insulin. That is very easy to start. So basal, I already told you 10 units at the bedtime. And the premixed insulins maybe 10 to 15 units BD. So that is the best way of initiating the insulin. Importance of tailoring the insulin as per the patient's need. So average BMI. So when the fellow is BMI is reducing, that means weight loss is there, then there is always an insulin. When the fellow is overweight, so then the blood sugars will be well controlled with your diet, with your exercise, with your metformin, with your GLP-1 receptor agonists, or with your SGLT inhibitors, etc. Beta cell dysfunction, so definitely you need the insulin. High PPG excursions, so sometimes you will need the prandial or the premixed insulin. High carbohydrate diet, so in spite of your 2 or the 3 antihypertensive, anti-diabetic drugs, so definitely you need a prandial insulin here. So here is about 60 years age, but the picture looks like 90 years. Type 2 diabetes, treated for the 8 years. Patient was inconsistent with the follow-up. So poor, typical Godavari patient. Weight 72 kgs, BMI 25, BP normal, heart rate is also normal. A1C 9.3, fasting 170, PP 280, creatinine 1.1. If you see the GFR 65, urinary albumin creatinine ratio 70. In all our type 2 diabetes, please check the urinary albumin creatinine ratio. So that is the most earliest way of knowing the diabetic nephropathy. So reason for visits, uncontrolled blood sugars, dietary pattern, unpredictable, family history, so strong family history is there. Now the medication is getting DAPA 10 mg, Seta 100 mg, metformin 2 grams, telmisartan 40 mg, chlorothalidone 6.25. So is both diabetic and hypertensive getting the ideal good drugs. He's getting SGLT inhibitor, he's getting the gliptin, he's getting the metformin, he's getting the ARB telmisartan with a diuretic. So choose the premix insulin, but still the A1C is 9.3%. Fasting high, postprandial is also high in spite of these drugs. So what to prefer is the premix or the basal insulins. So when the basal insulin we use when the fasting blood sugar is very high, or when the HbA1c is somewhere between 8, 8.5 or the 9, etc. So when the PP is very high, in spite of the 2 or the 3 hypoglycemic agents, so definitely there is a role for the premix insulins. So as time is very short, I am running fast. So addressing the durability of the basal or the Humalog is the premixed insulins. So obviously Humalog scores for the basal insulin because HbA1c reduction will be high, the fasting blood sugar reduction will be high, postprandial blood sugar reduction will be high, and hypoglycemia a little bit higher in the premixed insulins when compared to the basal insulins. Another case, a type 2 diabetes of 10 years, consumes high carbohydrate regularly, is just 51-year-old, BMI is 28, is the overweight, BP is okay, but diastolic C in the 90, the systolic 128. So systolic may be normal, but the diastolic here is the 90. So the diastolic hypertension is very common in hypothyroidism. So here you check the thyroid profile. So glucose HbA1c 9, fasting 165, postprandial 270. Again USER 72. Normal is 30. So he is having the diabetic nephropathy. Again the same reasons. So see the home blood glucose monitoring. So ask them to buy one glucometer. Now the glucometer is also very cheap. Maybe 500, 1000, 1500 we are getting it. And sometimes we get the samples also. So we give the patients a free glucometer to all the GDM population, etc. So check the blood sugars on Monday, Tuesday, Wednesday, etc. One day on the fasting, one another day on the pre-lunch, another day on the pre-dinner, some day on the and this is the log book. So definitely you can see. So at what time the blood sugars are very high. Carbohydrate rate is very, very high in our population. High glucose load in the Indian diet. So Lispro definitely will help in controlling the both. So this is how we have to check the blood sugars. See, after the starting of the insulin, so definitely the blood sugars will come down both the fasting and the postprandial. And HbA1c has come down to the 7.3 from the 9.8. So in conclusion, over 80% of the people with type 2 diabetes in India have poorly controlled blood sugar levels, with an HbA1c more than 7% in spite of taking 3 OADs. Controlling the fasting hyperglycemia is a crucial, but it is often insufficient to achieve the HbA1c objectives of less than 7%. Control of the postprandial is also very critical. Lispro mix 25 shows a greater durability compared to the basal insulin, and it is very safe and effective choice as a starter insulin in patients requiring the tighter postprandial glucose levels. So thank you very much for your patient hearing.